I'd like to acknowledge the traditional custodians of the land on which I'm recording today and pay my respects to elders past and present. I'm Kate. I'm an Australian pharmacist with more than 25 years of experience working across hospital pharmacy, community pharmacy, palliative care, aged care, and now voluntary assisted dying. Welcome to Pop Pod, the clinician edition of Prescribe or Pass. Look for me on Instagram, TikTok, Facebook, and YouTube at Prescribe or Pass. Every episode explores one medicine, one condition, or one clinical concept, explaining not just what we do, but why we do it. Whether you're a pharmacy student, pharmacist, or any clinician who works with medicines, welcome to the Pop Pod. This is episode 3 in our ADHD series. In the last episode, we explored why ADHD medication is not chosen according to how severe someone's ADHD is, and why two people with the same diagnosis may be prescribed completely different treatments. Today, we're narrowing our focus to one medicine, methylphenidate. Not the brands, not the different formulations, just the molecule itself. By the end of this episode, you should have a better understanding of how methylphenidate affects dopamine and noradrenaline signaling, why those effects can improve attention, working memory, and impulse control, the difference between immediate release and modified release treatment at a broad level, what patients may realistically notice when treatment is working, how methylphenidate can affect appetite and sleep, the key counselling points for safe and effective use, and what clinicians should monitor before and during treatment. This is part of an 8-part series on ADHD medications. Each episode builds on the last, so while you can listen to them individually, you will get the most out of the series by following it from start to finish. And by the end, you'll have completed around 2 hours of education. And if you're using this podcast as part of your continuing professional development, I finish each episode with reflective questions to help consolidate your learning and give you ideas for your CPD record. In this episode, we're going to look at what methylphenidate, the molecule, is, what it does in the brain, what patients can expect from it, and what pharmacists and other clinicians need to know when supporting its use. To reiterate, after listening to this episode, you should be able to explain the mechanism of action of methylphenidate, describe its expected clinical effects, discuss common adverse effects and practical counselling points, outline appropriate monitoring during treatment, and recognise when further review or referral may be required. Methylphenidate is a central nervous system stimulant and remains one of the first-line treatments in ADHD in both children and adults. The word stimulant often confuses people. If someone already struggles with hyperactivity and impulsivity, why would we prescribe a stimulant? Surely that just makes things worse. Yet for many people with ADHD, stimulants don't make them feel wired. They describe something quite different. They say their thoughts feel quieter. The background noise or chatter is dimmed, which means they can finally finish a task. They can listen without their mind jumping elsewhere. Many even describe feeling calmer. This isn't because methylphenidate is sedating, because, as we know, methylphenidate is classified as a stimulant. It's because it improves the efficiency of the brain networks responsible for attention, planning, and self-control. How do brain cells communicate? To understand methylphenidate, we first need to understand how neurons communicate. Imagine two nerve cells standing very close together but not actually touching. The space between them is called the synapse. When one neuron wants to send a message, it releases neurotransmitters into that gap. Two of the most important neurotransmitters involved in ADHD are dopamine and noradrenaline. Those neurotransmitters bind to receptors on the next neuron, passing the message along. But they don't stay there forever. Once they've delivered their message, specialized transporter proteins act like tiny vacuum cleaners, rapidly removing the neurotransmitters from the synapse and recycling them back into the first neuron. This recycling is essential. If dopamine simply accumulated in the synapse, signaling would become noisy and inefficient. The brain needs neurotransmitters to appear, deliver their message, and then be cleared away so the next message can be transmitted accurately. So where does methylphenidate work? Methylphenidate primarily blocks two of those recycling transporters. the dopamine transporter, often abbreviated to DAT, and the noradrenaline transporter, or NET. When those transporters are blocked, dopamine and noradrenaline remain in the synapse for longer. Importantly, methylphenidate is not making new dopamine, it isn't replacing dopamine, and it isn't correcting a proven dopamine deficiency. Instead, it allows the dopamine and noradrenaline that have already been released to continue signaling for a little bit longer before being recycled. That small change has surprisingly large effects within the brain circuits responsible for executive function. There's another interesting pharmacological point. In many parts of the brain, dopamine is mainly cleared by dopamine transporters, but in the prefrontal cortex, the area most involved in attention, planning, decision-making, there are relatively few dopamine transporters. Instead, dopamine is removed largely by the noradrenaline transporter. That means that when methylphenidate blocks NET, it doesn't just increase noradrenaline, it also indirectly increases dopamine within the prefrontal cortex. It's quite an elegant mechanism. Why isn't more dopamine always better? One of the biggest myths about ADHD is that it's simply caused by low dopamine. Reality is far more complicated. Neuroscientists often describe dopamine and noradrenaline signaling using what's called an inverted U-shape curve. Imagine a hill, too little dopamine, and executive functions perform poorly. But too much dopamine can also impair attention, working memory, and decision-making. The brain works best somewhere near the top of the hill, where neurotransmitter signaling is neither too low nor too high. It's just right. The goal of treatment isn't to maximize dopamine, it's to optimize it. And that distinction matters because patients will often ask whether a higher dose will work even better. Sometimes a higher dose simply increases adverse effects without improving concentration. Executive function. We use the term executive function a lot, but what does it actually mean? Executive function is the collection of mental skills that help us organize our lives: planning, prioritizing, starting tasks, switching between tasks, holding information in working memory, managing emotions, resisting impulses, monitoring our own behaviour. Think about walking into a room and immediately forgetting why you went in there. Or opening your email, knowing exactly which message you need to reply to, yet somehow you find yourself reorganising your desktop instead. Or meaning to pay a bill every day for 2 weeks, but never actually getting started. These aren't problems with intelligence, they're problems with executive function. When methylphenidate improves signalling within these brain networks, patients often describe feeling less mentally cluttered, not euphoric, not artificially focused, simply better able to direct their attention where they want it to go. How quickly does it work? Unlike medicines such as atomoxetine, methylphenidate starts working from the very first dose. That doesn't mean every patient notices a dramatic improvement immediately. Some people experience a profound difference on day one. Others require several dose adjustments before finding the right balance between benefit and adverse effect. It's also important to remember that medication doesn't instantly undo years of learned habits. Someone who has struggled with organisation for decades may suddenly have the neurological capacity to organise themselves, but they still need time to build those routines. Medication might open the door, the patient still needs to walk through it. A brief word on pharmacokinetics. After oral administration, methylphenidate is absorbed relatively quickly from the gastrointestinal tract. It undergoes significant first-pass metabolism, meaning not all of the swallowed dose reaches the systemic circulation. Most of the drug is metabolized by an enzyme called carboxylesterase 1, often abbreviated to CES1, into an inactive metabolite known as ritelinic acid. Unlike many medicines, methylphenidate is not extensively metabolized through the cytochrome P450 system, which means it has fewer CYP-mediated drug interactions than many clinicians might expect. Most metabolites are then excreted in the urine. We'll return to pharmacokinetics in much more detail next episode because understanding how the drug moves through the body helps explain why different formulations can behave so differently. What should patients expect? Patients expect to feel completely different, but the goal isn't euphoria, and it isn't feeling energetic, and it certainly isn't feeling high. It's improved function. Patients often describe being able to finish tasks, Listen without constantly drifting away. Reading a page without needing to restart it 3 times. Remembering appointments. Interrupting people less often. Feeling less overwhelmed by everyday life. Sometimes it's the patient's partner, teacher, or work colleague who notices the improvements first. What methylphenidate doesn't do. It's equally important to understand what methylphenidate does not do. It doesn't cure ADHD. It doesn't make someone more intelligent. It doesn't teach organisational skills. And it doesn't replace sleep. And it doesn't replace psychological therapy. And it doesn't remove the need for exercise, healthy routines, or good mental health care. Instead, it reduces some of the neurological barriers that make those things harder. Medication is an important tool, but it's one tool in a much larger toolbox. Appetite. Reduced appetite is one of the most common adverse effects. Exactly why this occurs isn't completely understood, but dopamine and noradrenaline are involved in appetite regulation within the hypothalamus, and stimulant medicines appear to reduce the normal sensation of hunger whilst they're active. Patients often say something quite interesting. Not that food makes them feel sick, although for some this is true, but just that they simply forget to eat, or they realise at 4 o'clock in the afternoon that they've had nothing since breakfast. And this is where pharmacists can make a real difference. Encourage patients to eat a good breakfast before taking the morning dose. Keep lunch simple and convenient. Choose energy-dense snacks if needed. And remember that appetite often returns in the evening. For children and adolescents, ongoing monitoring of height, weight, and growth is particularly important. Sleep. Sleep is another common concern. At first glance, it seems obvious that stimulants should cause insomnia, and sometimes they do. But sometimes the opposite happens. Many people with ADHD struggle to switch off at night because their thoughts race constantly. When their symptoms are better controlled during the day, they actually find it easier to relax at bedtime. On the other hand, if medicine lasts too late into the evening, it may delay sleep onset. Timing matters and dose matters and the formulation matters, and we'll spend much more time discussing formulation in the next episode. Common adverse effects. Like every medicine, methylphenidate has adverse effects. Most are mild, dose-related, and improve with careful titration. Common adverse effects include reduced appetite, insomnia, dry mouth, headache, nausea, abdominal discomfort, mild increases in heart rate, small increases in blood pressure. Some people also notice irritability or emotional lability as the medication begins to wear off, a phenomenon sometimes referred to as rebound. Less commonly, patients may develop tics, mood changes, or worsening anxiety. Rarely, more significant cardiovascular or psychiatric effects can occur, highlighting the importance of appropriate assessment before treatment and ongoing monitoring afterwards. Counselling. When dispensing methylphenidate, pharmacists have an important opportunity to improve both safety and adherence. Patients should understand exactly how and when to take their medicine. They should avoid changing the dose themselves without medical advice. They should tell their healthcare team about any prescription medicines, over-the-counter products, or complementary medicines they are taking. Although methylphenidate has relatively few CYP-mediated interactions can still occur through other mechanisms, and complementary medicines are often completely forgotten during medication histories. Because methylphenidate is a Schedule 8 medicine in Australia, patients should also be reminded not to share their medication with anyone else and to store it securely. Unfortunately, diversion of stimulant medicines does occur, particularly amongst university students and young adults. And finally, remind patients that if they experience chest pain, fainting, persistent palpitations, severe mood changes, or suicidal thoughts, they should seek urgent medical review. Monitoring. So what should clinicians be monitoring? Before treatment begins, a careful medication history should explore any personal or family history of cardiovascular disease, arrhythmias, or sudden cardiac death. During treatment, we commonly monitor blood pressure, heart rate, weight, height and growth in children, sleep, appetite, mood, functional improvements, and adverse effects. Remember, successful treatment isn't simply about improving an ADHD rating scale. It's about helping patients achieve meaningful goals, completing university, keeping a job, driving more safely, managing relationships, parenting more effectively. Those are the outcomes that really matter. Key practice points. Let's finish this episode with some key messages. Methylphenidate is a central nervous system stimulant that works primarily by blocking dopamine and noradrenaline reuptake. Its greatest effects occur within the brain's networks responsible for executive function. Treatment aims to optimize neurotransmitter signaling, not simply increase dopamine. Most benefits are seen from the first dose, although dose optimization does take time. Reduced appetite and sleep disturbance are among the most common adverse effects. Pharmacists play a critical role in counselling, monitoring, identifying interactions, and supporting safe use. As part of your continuing professional development, consider this reflective question. When counselling someone who is starting methylphenidate for the first time, which 3 counselling points are most likely to improve both adherence and clinical outcomes? And would your answer differ for a child, an adolescent, or an adult? Thanks for joining me for another episode of Prescribe or Pass, the Pop Pod. Today we've focused on the pharmacology of methylphenidate itself, but every pharmacist knows methylphenidate isn't just one medicine. It's available in multiple formulations that release the drug in very different ways, and those differences can have a profound effect on symptom control throughout the day. Next episode, we'll compare the formulations: Concerta, Ritalin LA, and immediate release Ritalin. Also the generics. Are they really a direct swap? Follow me on social media at Prescribe or Pass, Facebook, Instagram, TikTok, and YouTube. I'll see you next time. Bye-bye.